treatment for endometriosis. Urinary endometriosis is extremely rare, affecting only 1 to 2% of patients with endometriosis. Bladder involvement is the primary site of disease in 18% of cases. This is defined as the presence of endometrial glands or stroma within the destructor muscle. It can cause chronic pain, urinary urgency, polyuria, urgenturia, dysuria, urinary incontinence, or hematuria. French guidelines recommend surgical treatment if medical therapies fail. We have two types of procedure, each an abdominal approach involving partial cystectomy on an extramusical resection of the nodule by laparoscopy with or without a robotic assistant, or a transvesical endoscopy approach via transurethral resection, but the second option is not recommended. This kind of disease is uncommon, so there is limited data in the literature regarding surgical management. We find that there is limited data on urinary symptom assessment, that no study have examined quality of life, and that nearly no study use validate and reproductive evaluation score. So we therefore define our objective with a primary objective being the assessment of urinary symptom and quality of life before and after surgery. The secondary objective was to increase descriptive knowledge regarding the surgical management of patients with bladder endometriosis. It was a retrospective study. We include all patients who underwent surgery for endometriosis bladder lesion at the Besançon University Hospital from January 2017 to April 2025. We emailed questionnaire to collect data on patient pre-operative and post-operative status regarding the urinary symptom and quality of life. For this purpose, we choose to use the validate APSS and EHP30 questionnaire. During this period, 23 patients underwent surgery. All patients have failed medical management, in most cases hormonal therapy. 100% underwent MRIA. The mean age was 36 years. We excluded one patient due to language difficulty. In total, we surveyed 18 questionnaire responses, representing an 81.8% response rate. The mean follow-up period was 39.4 months. 4 patients have previously received surgical treatment for deep endometriosis, and in 3 out of 4 cases, it involved bladder lesion. Among the patients studied, 16 underwent concomitant surgery for other endometriosis lesions. There were deep lesions in 55.6% of cases. Patients were hospitalized for an average of 3.6 days postoperatively and required a urinary catheter for an average of 9.3 days. Among the 33 patients who underwent surgery, there were no serious complications. However, there were 4 no serious complications. Post-operatively, improvement was observed in hematuria, dysuria, polyuria, urinary pain, and urinary urgency. This improvement was statistically significant for dysuria and urinary pain. An improvement was also observed in the APSS score, which decreased from moderate to light, and with improvement was statistically significant. There was a significant improvement in quality of life, with a 28.5-point reduction in score. This improvement concerned the overall score and an all subcategory. It represents a significant improvement across all subcategories except for parenting. However, endometriosis causes infertility, so this subcategory includes few patients. There is some information concerning patient fertility. The pregnancy rate among patients with infertility was 58.3%. Our study has several positive points. First, we have a good internal validity, as well as a few exclusion criteria and high response rates. And characteristics of our study population are similar to those of the general population. Our study also demonstrates strength in external validity. First, we have a pregnancy rate of 58% among infertility patients, which is comparable to the literature. And regarding the complication rate, we observe that is vary in the literature, but our rate of 22% is very close to the Philips study, which is the largest study evaluates post-cystectomy complication. Regarding quality of life, there is a first study on the subject, but Selvi, Dogan, and all have rarely studied post-surgical improvement for other endometriosis localization and found similar results. Our study, though, however, have limitation. First, it is a single center study. Due to the extremely rare nature of the condition, we have a small number of patients. Finally, the fact we collect data on our primary outcome measure retrospectively expose us to significant memory bias, which is our main source of bias. Furthermore, our primary outcome measure is poorly subjective, as it involves assessment of subjective validation. In conclusion, it was the first study using validated questionnaire showing that surgical management reduced lower urinary tract symptoms and improved patient perception of this disorder. We observed a significant improvement in quality of life, however long term. However, given a relatively small sample size, further multicentric study would help supporting our conclusion. Thank you.